wanted to give some update about trials in the Royal Melbourne Hospital, but I realized a lot of trials in NPC specifically has been sort of outlined in greater detail at by the various drug trial companies. So I thought I wanted to discuss briefly about all the trials that we run as a team of neuropsychiatry team and neurosciences team at the Royal Melbourne Hospital, so that it gives an opportunity, a showcase for you and also other drug company who wants to bring on their drug trials to make it happen at the Royal Melbourne Hospital, happened in Australia as well. A bit about myself. I started learning about neurological diseases in a bit more sort of methodical form in Western Australia, in at this place, Greylands Hospital. They have the young onset dementia unit, a lot of metabolic disorders in over 18. They have a Huntington disease unit, which is where I started looking into genetic diseases and neuropsychiatric management and research around that. So I might actually start with talking about Huntington disease, something a bit different, and see how that sort of translate in terms of the comparisons in NPC in terms of the progress in that particular illness. So Huntington disease is a genetic neurodegenerative disease. It is an autosomal dominant. So if one of your parents have Huntington disease gene, they will be affected, and there's a 1 in 2 chance that your children would have the gene and will develop a Huntington disease as well. The typical manifestations is around the middle ages, but there's also a juvenile version of it, a late onset version of it, just like an NPC. And where neuropsychiatrists are involved with this, there's diverse manifestations around this. There's neurological motor problems that comes with Huntington disease. There's the cognitive and psychiatric, alongside schizophrenia, bipolar disorder, mood disorder. In the general sort of teaching session in medical school, we often talk about this dancing-like choreographic movement in someone who had Huntington disease. Over the last few years, we've actually started to get a lot more trials in terms of disease-modifying trials that is available in Huntington disease, something that hasn't been available, 5 years ago, or even slightly earlier than that. These are the sort of trials that Dr. Yahweh had mentioned, using sort of mRNA. Again, Dr. Tony Cook has mentioned as well. Some of the trials, you can actually bind into the abnormal gene expression into the protein and stop that process of making the abnormal Huntington proteins. And we've run various trials, for example, the Roche trials, where you can actually lower both the normal and abnormal proteins, because in adults it's thought that even the normal proteins that everyone else have in the world, including myself, is thought to be not of importance in adulthood. So one of the trials is actually looking into this. One of the things that we do in terms of making sure this drug get into the brain system is lumbar puncture. We infuse the drug using local anesthetics, take a little sample of the cerebrospinal fluid, and then deliver the drug that way, which is the intrathecal delivery, similar to the older version of cyclodextrin studies. Unfortunately, it's not all that simple. There's pitfalls, and there's actually a lot of failures so far in terms of whether we can actually lower the proteins successfully. It doesn't necessarily mean that it will improve things in terms of the outcomes. And that's something that the drug trials, the drug company is looking into. They're looking into subgroup of the studies. In the original study, recruited over 300 patients across the world, internationally, and they found that those who are younger and less severe in the disease process seems to benefit, whereas others didn't seem to benefit when they get infused with placebo or the drug. There's also other versions of mRNA that we've been involved in. Again, someone mentioned about some of the drug is negatively charged, hence they can't get into the cells. This was the issue with this particular two trials. The newer version of the trial seems to be successful of the drug at looking into lowering just the abnormal version of the Huntington's proteins. Where some of the earlier trials might look into involving us. For example, some of the interesting drug, the DL33 that Dr. Wachin mentioned, is that we've been involved in phase 1 trials as well in Huntington disease using tablets that can actually lower the abnormal proteins quite effectively, and it presents itself as a very attractive drug to for the population in the future. So those trials in Huntington disease are up and running. We've got infusions, we've got different phases of the drug trial, we've got open label as well. Now, the other trials that we've been involved in is Prion's disease, also known as Creutzfeldt-Jakob disease. Several decades ago, there's an outbreak in the mad cow disease. That's a rare form of this particular disease. Most of it is sporadic. There is a genetic cause in many of these diseases. It is quite a rapidly progressive disease. By the time you get diagnosed, the prognosis is within weeks or months in terms of survival. In some ways, it resembles a very intense, untreated, severe NPC, where you get this delirium, confusion, seizures, ataxia, a lot of movement problems, incontinence, because a lot of the anatomical components that is affected in Prion's disease is also affected in NPC at much rapid stages. We've been approached by the local legend, Professor Colin Masters, who are very much a prolific researcher in Alzheimer's disease, well known all over the world, and he asked us to conduct these studies in Prion's diseases because that's one of his main interests. And we said, okay, we'll make it happen. And essentially, we've been infusing participants with similar mRNA trial to silence the gene that encodes the prion so that we can actually stop it from producing itself and create the damages that the Prion's disease causes. So these are very difficult and devastating disease. By the time we start calling people to recruit them, a lot of them would have passed away. The people in the trials have passed away so far. Been getting thankfully the slower progressive version of the illness, and been successfully infusing these trials and still sort of up and running. And then there's Professor Mark Walterfang, who's come and approached me several years back. If you don't know him, he's a neuropsychiatrist at the Royal Melbourne Hospital, recently just resigned. But if you get a chance to meet him professionally, all he talks about is Niemann-Pick Type C all the time. And I come to see him from time to time and see some patients with Niemann-Pick Type C, and he's inspired me a great deal about how to approach someone who with a rare neuropsychiatric illness, and not just from clinical aspect, but also from a research perspective. He's obviously published a great deal in this field. Talked about what Niemann-Pick Type C is in a recent paper in collaboration with a whole bunch of doctors that he inspired, some of those who are trained with me at the time. Again, just don't want to bore you about what Niemann-Pick Type C is, but we know it's an ultra-rare disease. It resembles to some of the disease that I mentioned before, but even at a rarer sort of prevalence. Its onset varies from infancy to mid-adulthood. The typical manifestation is that of ataxia, dystonia. There's an abnormal eye movement that is vertically sort of impaired. Where we get involved is the neuropsychiatric symptoms, the cognitive problems, the psychosis, the bipolar. And there's also other systemic involvements like the enlarged spleen and liver. At its core, there's this abnormal lipid buildup or lipid trafficking or fat trafficking within the neurons or the brain cells. And when you look at it in a microscope, you get this swelling of the parts of the neurons, the axons, the neurites. And when you stain it for lipids or fats, you get this enhanced accumulation of cholesterol and gangliosides in the neurons. And when you stain it with proteins that are associated with dementia like tau, amyloid, it does show up that there is a buildup of tau and amyloid within the brain cells. It contrasted similarly and also differently to Alzheimer's disease, just as a little sort of outline in normal brain, in the neurons, there's not much sort of tau tangles or buildup of tau protein that gets tangled up in the neurons. In Alzheimer's disease and NPC, you do see a great deal of that. In terms of amyloid, there's a lot of amyloid in the brain cells of people with NPC, but not in outside of the neurons where you get to see that changes in Alzheimer's disease. So what that means is that what we understand from NPC or what we understand from Alzheimer's disease can be translated between each other. So not only that something that we learn from Alzheimer's disease can apply to us, we can also apply the findings in NPC for Alzheimer's disease. For example, Prof. Walter Fang, again, has looked into tau traces where you can actually stain tau in real time and put people in the scanners. I appreciate that a lot of the participants are local in this particular neuroimaging study. And you could, as you can see, the color, the enhanced color in red, green and yellow and orange are indicating where there's a buildup of tau compared to the healthy controls on the top picture there. I was involved in one of the particular imaging studies where we collaborated with people in the States and New Zealand looking at the memory centers, the hippocampus, where actually you can see in the hippocampus, there are subregions where there are a lot more neurons, where the tau gets deposited, and it causes a shrinkage in those regions. Whereas there are also other subregions, there's not a lot of neurons where it's mostly interneurons, where it's largely preserved. Interestingly, in Huntington disease, it's actually the opposite direction. So what you can see here in red and orange is the region where it's shrinked disproportionately, whereas the green part is actually the ones that's preserved. So those are the sort of segue in terms of Prof. Walter Fang introducing me to the various treatment trials and studies in Niemann-Pick Type C that's available at the Royal Melbourne. I understand a great deal of patients that we see are taking miglustats from the previous trials that's been happening, the involvement of Professor Mark Walter Fang. I have been largely involved in the cyclodextrin, IV cyclodextrin, and the NALL or levoacetylleucine or Aquinersa trials. And all these drugs are thought to improve the lipid and glucose metabolism in the neurons. I think we've discussed about cyclodextrin a great deal. Essentially, it's a little bit like a soap where the compound sugar can bind to the cholesterol and helps to clear out that cholesterol out of the brain cells. As a result, there's a less burden of that cholesterol within the brain cells. It's a treatment that people come to from all over Victoria, Australia, every fortnight. They sit down for about 8 to 10 hours, receiving the actual treatments in the day procedure department at the Royal Melbourne, and we're running the Trapsol trial. I think at the moment it's in the open label trials, and from personal experience, most people are pretty much at the plateau stages of the illness, and it seems to be quite relatively stable in terms of how people are going at the local level. I think we've also discussed about this, just a little slides to show you that in pink is where all the lipids are built up when you infuse this particular brain tissue. At 14 weeks, it does show a clearance of that cholesterol buildup in this brain tissue. Leucine is a very interesting study. It's been discussed numerous times across today and yesterday. It's previously, there was this drug called Tanganil, which combines the D forms and the L forms of the isomers. And some researchers are starting to look into the various forms of the isomers, and they started experimenting on them, and they found that the L isomer shows a lot more promise, and it does seems to synergize its effect with miglustat and mouse model. And what that means clinically is that it is quite remarkable, because ataxia metabolic disorders can respond really remarkably with this sort of treatments. Let me just give you a little example of that same paper. This is someone with adult onset Tay-Sachs, a type of metabolic ataxia disorders, female in her 30s, quite staggered in her ability to walk, difficulty with dystonia of the upper limb, difficulty with turning at baseline. And once you start treatment with some forms of Tanganil or leucine, you see that there's a smoothness of that movements after 1 month. It is quite remarkable. And that was essentially my initial impression of walking up and running, being part of the trials in the IntraBio study. Why is it that the D and the L forms of leucine is more sort of effective? No one was really quite sure, but there are some studies that suggest that the L forms of leucine seems to preserve the brain cells. This is the Purkinje cells, which are the cells in the cerebellum, which is highly metabolically active and implicated in NPC. Seems to be well preserved when they take the L form of leucine, comparably to D form on the right there. There's a less preservation of that red intensity, suggesting that perhaps it's not as neuroprotective. And conversely, when you stain it for that inflammation or microglia activation, or the cells that clean up the tissue destruction, there seems to be less of that when you're taking the L-leucine. Again, all the same papers, and hence it's really inspired the subsequent studies. And this is, again, the last sort of forms of biology that I could sort of stretch in terms of what leucine means. It seems to be a component of the membrane that is associated with the lysosomal function. So the lysosomes are part of where the lipids are trafficked in and out of brain cells. So we thought that possibly that might have some implication in terms of activating that. I was grateful to be part of this trial and be involved in actual publication of this trial at 12 weeks, as Mark Patterson mentioned and Taylor Fields mentioned, that we did find quite a significant improvement internationally as when people are on the N-acetylleucine compared to placebo across different age, sex, stage of illness. Possibly it seems to affect best in the younger form of NPC. What is interesting that and replicated within the study is that it synergized well with miglustat. That's something that they found in mouse models and also now in real life. What does an acetylleucine look like? It looks like a KFC sachet tissue, sort of a wet tissue towel. You open up, and then there's granules in there, mix it in water, and you drink it. I think it's got various flavors to it. No one's really complained about the flavors. I asked them. Some people may benefit from the concocted version and be infused using the PEC feeding tube as well. So what it means for NPC, it's very relatively successful, but actually it's been translated across different diseases, Parkinson's disease, Tourette's, REM sleep behavior, lots of different other ataxia diseases are looking into this. There are case series of this. So it's a very successful, potentially broad spectrum treatment for everyone else with ataxia disorders. We did discuss about arimoclomol, the Milpliva studies. It's been FDA approved. Obviously, both miglustat and arimoclomol is not readily available on PBS in Australia. I think I was on a talk about 5 years ago that it was being trialed in motor neuron diseases with limited to little success then. So I think they've been hitting a very successful finding in Niemann-Pick Type C. We hope that it will be available for us in the near future. As a virus, I guess it's a little bit of some promotion here. They have reached out to us to consider running the trials, and we are looking for people if you're over 18 and looking into starting a treatment for NPC and not on miglustat. It is something that we might be able to run soon. They are looking for various candidates all over the world as well. It seems to be a very attractive drug from our perspective, being once a day dosing and possibly dispersible sort of tablet where you can actually dilute it in water. It's not a matter of us not being able to run it. It's just a matter of people coming in to see us and wanting to be a part of it, essentially. So on top of, I guess we talked about the research team who's been involved in it alongside with us. We work in parallel with the clinical team at the neuropsychiatry department, where we see a lot of people under 65 affected with neurodegenerative disorders. We work through in the multidisciplinary team. For example, there are some participants on some of the trials that have shown major improvement after they've had all this NDI support that can actually sit down with them and monitor their medication taking, as opposed to previously where it was quite patchy, and hence adherence was something that can be facilitated not just within the trial but also within the clinical setting. I think that's it. Thank you, everyone.